Yeah, okay, good. Right, so we'll play a little bit now with a little bit of evidence and also cases. And it is really important, because we have cases, to have some microphones around. Because we have cases, it would be nice to have some microphones floating, if possible. And if the microphone is not there with you, just shout. So these are my conflicts of interest. And I would like to go back to this slide. That's one of my favorite slides these days, because it shows the amount of weight loss. I presented it earlier on. It shows the amount of weight loss that people need to lose in order to improve their own obesity-associated complication. And we've talked about the 5% weight loss benefits. Here we start moving into more resistant territory when we're talking about cardiovascular disease, NASH, not just fatty liver, sleep apnea, certainly functional disease needing more weight loss than metabolic and hypertension outcomes. And then we start getting into here with 15%, they are the really difficult ones to treat with weight loss, and they are more resistant. So what does this mean? That it means that even though, again, our treatments for obesity remain crude, they will get better, but they will remain, at the moment they are crude, at least we can start to think about personalizing the treatments with the limited evidence that we have. So when someone comes in front of us, we adjust the treatment depending not only on their body mass index, but also the complication of the obesity that they are coming to us with. And briefly, this is only, I won't spend too much time on this. These are some of the staging systems that you can use in your clinics in order to stage people in the same way that we do for cancer. And this is a system that was developed at King's College, and it's very easy. Everyone can remember it because it goes from alphabetically, from A down to I, and people are staged as having normal health, stage 1, stage 2, or stage 3 disease, depending on their obesity-associated complications. So that's a nice thing. It's easy to do. It's fast to do, even though it looks busy. And it is standardized. Another system, which is widely known in the world, is the Edmonton Obesity Staging System, developed by Arya Sharma and the Canadians. And here you see they also go from stage 0, 1, 2, 3, 4, and they classify people according to their complications. The only problem that I'm having with this system is that it is more difficult to move from one stage to the other. And they combine the physical, medical, and functional complications. So what Iba has just said is very, very true. This is the usual way that we treat obesity, with people starting with their own changes, then they come to us, and we do lifestyle changes, then we add medications, then surgery, and then surgery with medicine. But this is, for many people, this is the right thing to do. This approach is right for many people, but it is wrong for many others. Because if someone comes to us with a body mass index of 60, right, and diabetes, we cannot be taking them through this endless journey until eventually they need surgery with medicine, because it's very likely that they will need surgery with medicine anyway in order to improve their obesity complications. So we can go straight to this without having to waste our time and their time going through those steps. This is it's just about mixing. Sorry, Geltrude. This is Geltrude's 10-year data from the randomized controlled clinical trial data, comparing medical care with gastric bypass, Roux-en-Y, and with the biliopancreatic diversion. And what you will see is these are the rates of people with diabetes remission. 100% at 2 years, And I'm going to be looking at the gastric bypass graph, and what you'll see is that over the course of 10 years, the percentage of people with remission goes down, okay? And people see that and they start feeling disappointed that surgery stops working. That's the typical thing that people would say. And that's a wrong thing to say. Surgery is certainly still working. It is only that the progressive nature of diabetes is that it can escape full control of surgery. These people are still having good glycemic control, but they are not in diabetes remission. This is not failure of the surgery, and it is not failure of the individual. It just shows what the disease is like. And before I move on to the cases, these are data from about 12, now we have more randomized controlled clinical trials comparing bariatric surgery with, or metabolic surgery with best medical care for diabetes. And below here are the common predictors of response, okay? So duration of diabetes, so the sooner you operate on people, the longer they will benefit from glycemic control. The lower the insulin doses at the beginning, the better the longer-term control. And the lower the HbA1c at the beginning, before surgery, the best response they will have to surgery. Which means that if you take someone who's had diabetes for 25 years and they're on insulin, they may not achieve remission, but they will still achieve some improvements in their clinical outcomes. So this doesn't mean that surgery in those people doesn't work. It means that it works less well. So following on from what I have just said, let's just hear people's thoughts. I have 4 cases. Let's see how many we are able to do. So it will be a 50-year-old lady in all the cases. It's not, she just presents in different ways. She has got a new diagnosis of type 2 diabetes. You find her in your Amiri Hospital clinic with an HbA1c of 65, I didn't put the units, millimoles per mole. In percentage, it's going to be about 8, 7.5, no, 7.5, I think, yeah. I'm using the modern units. Yeah, 7.5% HbA1c. What do you do? Lifestyle modification will be your first. The body mass index is 45. Yeah, all of the cases, body mass index is 45. All of the cases that we're presenting are type 2 diabetes and obesity. GLP-1, but you said lifestyle. Okay, GLP-1. Anyone else? Okay, so lifestyle with medications. Okay? Sorry, people cannot hear.
Start with medications because her A1C level is high. It's 7.5. She's 50 and she's obese and she's recently diagnosed with type 2 diabetes. Yes, I would go with medications.
But why can you not do this just with modification, lifestyle modification?
Because the A1C level is high. It's about
it will come down.
6 and she's obese.
Okay, all right.
Yeah, so I don't know. This is the
people,
new guidelines.
No. There's no right answer in any of this.
Yeah, I would do that personally.
Okay, who would do something else? Oh, come on, you need to decide. You cannot, you need to commit. Who said surgery? Oh, you said surgery. Okay, why would you do surgery?
We need to discuss with her the option of
surgery.
No,
that's sitting on the fence. Forget about the options.
Okay.
The people come to the doctor to get advice. What would you advise the patient?
Well, I tell her there is a surgery can maybe solve your problem, remission of the diabetes. And she's 50 years, so we can extend her life and reduction of the complication of diabetes in the
Okay.
future.
So who disagrees with surgery? Hands up. Up. Okay. Many people disagree with surgery. Let's give some microphones to people in the back, not only the front. So whoever disagrees with surgery, can you tell us why? From the back. Who disagrees and why? No, you're for the front. In the back. Who disagrees? Come on, there were people who disagreed. Okay, they are not forthcoming. So, lady at the front. You disagree because you need to shout.
I disagree because there's a lot of things that can interfere with the medication. So the surgery will not solve the lifestyle. It will not solve the pattern of eating pattern. It will not solve the emotional eating if she suffers from.
Okay, see, it doesn't have emotional eating. See, eats healthily.
Okay. I'm the dietitian, so
Yep.
I think that sleeve and bariatric surgery have many complications when it comes to side effects. So rather than push the patient for a sleeve surgery, and I'm dealing with a patient with post-sleeve. So rather than that, we can solve many huge things that interfere with the patient.
So I would be interested to also hear the endocrinologist, because the evidence that I have just presented here, well, or evidence through these trials, is that the best time to intervene with bariatric surgery is either upon the diagnosis of type 2 or even in pre-diabetes. So this is where surgery becomes the most effective it is, both in terms of efficacy and probably cost effectiveness. So why would you not do surgery? Okay, but you still want to do surgery. Okay. So I think this is a difficult one, and there is no right or wrong answer. I'm just using it to hear your thoughts, because here we would be going completely contrary to what the evidence is telling us. The evidence are telling us if we did not do surgery. Even though clearly we have got the most cost-effective treatment, which is surgery, and this is the patient to apply it on. But I must agree with you that even though that the data is telling us that surgery should be the first-line option, even I would find it difficult to recommend surgery considering the pharmacotherapy that we now have. Now, a surgeon or someone else might say that with time, you know that pharmacotherapy will become less effective, therefore why don't you go straight to an operation? But again, with the treatments that we have, I think that this is tricky. Yeah.
I think that maybe that obesity comes under one. Diabetes is 7.5%.
Yeah.
Is not at least now.
Yeah. Yeah.
I think with 45, BMI 45, that obesity gonna harm before diabetes.
Yeah. 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 That's one certainly an option. All right. Same woman, diabetes now she's had for 10 years. Assume the BMI before surgery is 45. She's on metformin, empagliflozin, and liraglutide before the operation. She undergoes a sleeve, which is very popular in the Middle East. Do we have any surgeons in the audience? Good. The weight loss is, I'm joking, weight loss is 25%. She does very well 2 years after surgery. In the first year after surgery, her type 2 diabetes goes into remission. But at 2 years after surgery, the HbA1c is 60, which is again, as we have said, about 7.5 or so percent, whatever it is. So she has now gone into diabetes relapse. What do you do now? A question. Before the surgery.
So we'll put her back again on one of these incretin hormones again, and the incretin analogs. At the first signs
okay,
of
so you
weight
would put her back on medications?
Yes, at the very first sign of weight
okay.
gain, yes. And it's going to be like the incretin analogs that we have now in the market.
That's reasonable. What else? Who would do something else? We need more people from other parts of the room to give us answers, ideally with a microphone. Okay, who would convert her to a gastric bypass? We know that the gastric bypass is considered by many superior when it comes to metabolic control than the sleeve. And the kind of randomized trials have kind of shown that. She's lost 25% from 45. So weight loss perspectives, she still qualifies. Does it depend on the BMI? So the weight loss is done well.
Depends on the surgeon.
No, that's right. No, say that she's got a very good sleeve. Would you convert her to a gastric bypass? Yes, I like the yes. Let's hear why yes. No, with the microphone, yeah. Please, thank you.
The results itself between the sleeve and the bypass and the result regarding the hormonal effect.
Clinical effects?
Hormonal effect.
Huh?
Hormonal.
Yeah, but hormonal is one thing, but does the gastric bypass offer superior efficacy in terms of HbA1c and diabetes remission compared to the sleeve? Okay? But converting someone from the sleeve to the bypass, would that work much?
This I don't know.
Okay, what our expert audience and visitors think? I think Geltrude might convert her to a gastric bypass.
Yeah, the only surgical option. But I mean, usually in 2 years, sleeve gastrectomy will work if the surgeon would do a good job. So I'm just blaming the surgeon.
Okay. Yeah, so again, not a clear answer. Let me ask you another question. Since I like just the lady who talked about liraglutide, do we have any evidence that it would work?
It's just based on studies, but then I think that the first signs of weight gain or like type 2 diabetes, you should give a trial of these medications to the patient first before going ahead. I know the surgery is the ultimate solution for it, but like you have to try these new drugs that are down there in the market, especially now that we have a dual agonist, which is even better.
I'm talking about liraglutide now.
Liraglutide, yes. I think that according to what I'm seeing in my clinical practice, I'm a clinical pharmacist, there's a variation between like some people do respond to it, others don't. And it also
is it safe? Or not in your opinion, but based on studies?
Based on what? Yeah, it is safe, but the only thing that's like making people worry about it is that tumor thing with the thyroid glands. But
what
otherwise, what I've seen, it's been safe.
Yeah. What about? So you would have thought that the sleeve might. We need to move on. Actually, you would have thought that the sleeve would be associated with some GLP-1 increase. So
these surgeries, I know the bariatric surgeries are associated with an increase in the incretin hormone release. So one part of these surgeries being successful is due to the increase in the metabolic basal metabolic rate due to the the increase in the secretion of these hormones. I believe so.
Okay.
Yeah.
Okay. Let's move on to the third one, and we'll have to do this quickly so that I can show a little bit of data. So the same woman, same BMI and everything, same medications, undergoes a gastric bypass, the one that is considered the gold standard metabolically. Weight loss 25%, diabetes remission in 1 year, and now it's HbA1c of 60. What do you do now? She's got the bypass. Ketones. Why are you interested in the ketones?
So why A1C increased in spite of the body weight is okay now? So might be some sort of insulin deficiency.
Yeah, so you start thinking, well, yeah, but it's had diabetes for 10 years. You're right, it's possible. But it's a clear type 2, no ketones in the urine.
Yeah, okay.
Add insulin, not the other ones? Okay. I'll just show you, these are all great answers. I'll move on briefly to the data, and because time doesn't allow us. So this is the best meta-analysis I could find on the effects of conversion therapy, surgery, between different kinds of procedures to different kinds of procedures for diabetes remission. And on the face of it, it looks like some things do work. This is the evidence when it comes to converting things to a gastric bypass, various things. That's the problem. All of these studies are retrospective, case series, the definitions are unclear, the initial operation varies, but here they are showing that conversion to gastric bypass can increase diabetes remission rates. So if you had a sleeve to a bypass, that could work. The problem with meta-analysis in general is that they all depend on what you put in. If you put in nonsense, in terms of data, nonsense will come out. But on the face of it, it appears that there is some effect of converting a sleeve to a bypass, even though, again, in my experience, this doesn't look amazing. These are what the American surgeons have said. They have kind of agreed with that. And that they're saying that conversion to different kinds of procedures, the evidence is a little bit all over the place. And we know that the risks of a conversion surgery are much higher than the primary operation. So let's move on to, this is just the data. You knew I was going to present this. This is the only randomized controlled clinical trial we have to the use of liraglutide 1.8 milligrams. I'm showing this because it is specifically for people with diabetes. We use liraglutide 1.8 milligrams to people who had not achieved remission after sleeve or bypass, a double-blinded randomized study versus placebo. And what we find, this is why I was asking you earlier on, what we found is that liraglutide, at least for 6 months, was safe, number one, and it also reduced HbA1c and weight to the same degree that it does in people who have never been operated, which is very interesting. So it looks like it works in people who probably have got decent GLP-1 responses as well. Professor Bataram is going to produce hopefully soon, her evidence on Saxenda in use after bariatric surgery for people, I think, with or without diabetes, who have not got a good GLP-1 response. And briefly to say that it looks consistent with what we have found before. So we are now moving the goalposts. I'll finish off with these thoughts. We're now really moving the goalposts with what we can achieve with pharmacotherapy. And I heard that many of you were in favor of pharmacotherapy in treating those people. And these are my own personal thoughts on what is likely to happen, but I may well be wrong. And as we said, even though the evidence is clear that surgery is the most effective treatment for people with early onset, with recent onset diabetes, I would still go with pharmacotherapy because I think it will be more acceptable to the patient, and because we have got now really good data from really effective medications. Now, the surgeons will say to you that we do not have long-term data about these dangerous drugs. All the time. And they may well be right. okay? Because we have got evidence for all the good things bariatric surgery does, and many of them were presented by Geltrude for about 60 years now, right? In total, but the latest evidence has been for around 30 years. So we have got a lot of things about the good and the bad things surgery does, but we have got numbers, whereas with medications, we can only go up to 3, maybe 4 years, certainly with obesity treatments. With advanced type 2 diabetes, when someone has got diabetes for 20 years and they go for surgery, and they go for surgery, you know they will improve, but they will never reach the levels that you want in terms of glycemic control. It's impossible. It's how things are. The longer the duration, the worse the response is. Therefore, it's, I think, without thinking that we will be adding medications and we will be adding GLP-1 and GIP, etc. type of treatments. When it comes now to obesity, if we remove diabetes from the equation, I think that we are going to be flooded, really, as we already are, with people with body mass indices of 25 to 40. And with those people, with the newer medications that we have, a new achievement might be possible, and that achievement is achieving normal body mass index. Normal body mass index in these people, even up to a body mass index of 40, which for us recently has not been possible. Up to recently has not been possible. Now, I don't know if achieving normal BMI is a good thing or a bad thing or what it will cause, but it is something which at least now is conceivable. And in people who have got body mass indices over 40, then again, well, there's no reason to go up that kind of titration and direction of lifestyle, et cetera, because it is very likely that this person will need both medications, both surgery and medications. And if we combine those, even in someone who has got, for example, a body mass index of 55, we may be able to take someone with a body mass index of 55 with surgery plus medicine and drag them down to a normal BMI. Again, I don't know if that is a good or a bad thing, but it is conceivable. And don't forget that medications have got people who do not respond. Medications have got people who cannot tolerate them because of the side effects. And they are expensive, okay? So that's why I think I would agree with what was said earlier, that you see here that we still need surgery quite a bit if you consider all of these factors together. And therefore, we expect that over the next 5, maybe 10 years, the rates of operations, and that's a good thing, will go up, or hopefully will go up. And what will happen in the longer term in terms of whether surgery will become obsolete if the medications become even more effective, that's something to be, that remains to be determined. Finally, in terms of the cost of these medications, we all complain about the cost, and rightly so, and the patients complain about the cost. But remember that when statins or ACE inhibitors or proton pump inhibitors, even proton pump inhibitors, when they came out for reflux disease, they were very expensive. And there were only very few people in the National Health Service that they would be eligible for the medications. And now you can go and buy them over the counter without a prescription and at a very low price. And with pharmacotherapy for obesity, that to treat also diabetes, we're probably about 20, 30 years behind that state of affairs. But it will come to that. Thanks for listening.